Good morning. Welcome to discussion with a vascular expert today. I'm Aditya Sharma. I'm a vascular medicine physician and a member of Society for Vascular Medicine. I'm here today with Dr. Herbert Aronow, who's an interventional cardiologist, as well as the chair for American College of Cardiology, Peripheral Vascular Disease Section. He's also a board member for the Society for Vascular Medicine.
Thanks, Aditya. It's great to be here.
Great, thank you. And we are here today to discuss with him about renal denervation in the treatment of hypertension. So Dr. Aronow, could you tell us how renal denervation would help in the treatment of hypertension?
So this whole field really is fascinating, and the story is long. There's a history here that dates back even into the 1930s. So we've long known that overactivity of the sympathetic nervous system is an important component of hypertension, and we see this overactivity across the spectrum of patients who have elevated blood pressures. And back in that era, there were initial investigations that were undertaken to look at modifying the sympathetic nervous system surgically. And these were effective in that blood pressures were reduced in those with malignant hypertension, but they were also associated, these operations were associated with significant morbidity. This all occurred before we had availability of antihypertensive agents, and so this was sort of the only option at the time. Well, the morbidity of the procedure and the development of antihypertensive agents ultimately led to abandonment of this as a modality, but not the concept. So the concept has remained that modifying the sympathetic nervous system might be a means to try to reduce blood pressures. Well, this idea, in an era where we now have many catheter-based or endovascular approaches toward treating patients with vascular disease and with hypertension, has now led to a number of technologies which aim to disrupt the sympathetic nervous system, many of which aim to do so by disrupting the renal artery sympathetics, the afferents and efferents. Mm-hmm. So there's a wealth of animal model data showing that if you surgically disrupt the renal artery sympathetics, that you can lower blood pressure. What is novel now is that one can go in and use a catheter or even some type of external energy to disrupt these nerves. And so there have been a small number of preclinical studies, animal studies, primarily using pigs and mongrel dogs, that have demonstrated that radiofrequency energy and ultrasound when applied with a catheter, and even ultrasound when applied externally, may be able to damage these renal artery sympathetic afferents and efferents and ultimately lead to lower blood pressure. So I don't think there's much question anymore about the proof of concept. That is, that you could disrupt sympathetic nerves, and that might culminate in lower blood pressures.
Excellent, great. Can you tell us about the trials that have been performed so far?
So I think the trials are another very interesting story. Most of the companies that have launched into development of the new technologies, and there I believe are over 80 now, there's a lot of excitement and interest in this area. Most of them proved that the devices were safe in preclinical models, but weren't required to demonstrate efficacy. And so efficacy was left to the first in human studies that were performed. Mm-hmm. So there have been many studies that have been single-arm, uncontrolled studies where patients are exposed to some type of renal artery sympathetic modulation, denervation, if you will, where there's been a significant reduction in blood pressure that's observed early, meaning within weeks, and that seems to persist out not only to 6 months, which is the most common follow-up time point in most of the studies, but even out to 3 years. But those have been largely uncontrolled, and so one might question whether what was observed was truly therapeutic efficacy, or whether other factors might have been at play, whether those were placebo effect or medication changes. So it wasn't until Simplicity HTN-2 that there was a randomized trial that looked at this question. Now, that trial was designed for patients with so-called resistant hypertension. They had systolic blood pressures over 160 millimeters of mercury, and were on at least 3 antihypertensive agents, at least one of which was a diuretic. And they were randomized either to continue their current therapy or to renal denervation with the Simplicity catheter. that delivers radio frequency energy. And that was a positive trial, and there was a tremendous amount of excitement in the field about that because it looked like we finally had a new therapy that was not only safe, but efficacious. And that trial was conducted outside of the US, and Simplicity HTN-3 was the US trial, which looked at the same question. Now, there were some interesting differences in design of those two trials, and perhaps the most significant was that HTN-3 was a sham-controlled trial. So that means that all patients underwent a procedure. They all had invasive renal angiography, and some of them went on to have renal artery denervation with the Simplicity catheter, and others had a sham procedure where there was no further instrumentation. However, they remained on the table in the catheterization lab or angio suite. And that trial, whose results were recently published, did not find a significant difference in efficacy. It did identify that renal artery denervation was safe, but there wasn't a benefit. Both groups, the sham and the treatment arm, had significant reductions over time in blood pressure. 6 months was the time for the primary endpoint. In-office blood pressure reduction was the primary endpoint. They both groups, that is, saw significant drops from baseline to 6 months, but the drop was no different between the two groups. So, of course, that led to a lot of questions, which, chief among them, well, why would that be? Here's HTN-2, which was a positive trial, and here's HTN-3, which was not. And we can certainly explore some of that if you like.
Yeah, and that exactly was my next question, is why did we see this huge difference in outcomes?
So I think when one asks that question about any trial, why was this trial negative? You might ask the question, was there, was the biological basis that underlied the trial, was it plausible? Does it make sense that if you modify the sympathetic nervous system, in this case, that might have a benefit with respect to blood pressure? And I believe, based on the data, and that's not to say there's not much more to learn, but based on the available preclinical data, I believe that there is something there. We know that if you modify the sympathetic nervous system, it can be beneficial with respect to hypertension. The next question might be, okay, well, if we think that that concept works, did we select the right patients, right? So one might ask the question, was resistant hypertension the right population to test this question in? Should it be patients who have uncontrolled hypertension instead? One might ask the question about medical therapy. Should they all have been on aldosterone, as an example, antagonist, aldactone? One might ask the question about not just the patients, but about the design of the trial. Should it have been in-office blood pressure that we looked at, or maybe ambulatory blood pressure instead? Is that a more accurate reflection of where people spend their time as far as blood pressure is concerned? Was 6 months the right endpoint? Or should we have looked out to a year or further? Was the lead-in time appropriate for the trial? Was 2 weeks enough time to be on a quote-unquote stable regimen, or was it really not a stable regimen? Were there changes made just 2 weeks earlier that ultimately led to blood pressure reductions in both arms? And so did we not allow those medication changes enough time before testing something new? The questions go on and on. So was it the patients? Was it the design? Was it the outcome? You can ask finally about the technology. Was this the right catheter? Did it allow us to deliver the right energy? Is radio frequency energy the best means to do this? Or is it possible that ultrasound or beta radiation or local delivery of pharmacological agents or any number of other means for addressing this issue are superior? We don't know the answers to those questions yet. And is it possible that even if radiofrequency energy is appropriate, if it will allow us to accomplish the goal of reducing blood pressures by modifying the renal artery sympathetic nerves, is it possible that this particular catheter doesn't allow one to reliably do so? And that hits on one of the key shortcomings in this field right now, which is that we don't have a metric. So I'm an interventional cardiologist. If I put a stent in someone's coronary artery, I look at that picture when I'm done, and I can say to myself, or ask myself, was that a good result? Is that a good result? And I may say, you know what, I think there's still enough narrowing there. I need to go back and touch that up a little bit. I need to do a better job. Well, we had no idea with renal denervation, and I can say this as an operator, we had no idea whether we did a good job or not. There was no way at that instant to know whether you effectively ablated the renal nerves. And so there could be catheter design issues with that particular device, or it's possible that there were operator issues. Maybe if you were doing it and I were doing it, we would do renal denervation slightly differently, and maybe your way was better. We have no way of knowing that. And so I think that those possibilities actually are very strong possibilities and may in part explain why we saw what we saw. So there have been a lot of sub-analyses that have gone on after the publication, most of which haven't yet been presented or published. And I don't know that anyone yet has the answer. What's clear is that there has been proof of concept. There's still tremendous confidence that there's something there. But I think there's an understanding that the trial was a setback to the progress. It was an eye-opener. And that it means it's going to take us a lot longer to get where we were hoping to get with this technology. And rather than perhaps an FDA approval by the end of 2014, we might instead be looking at something that's a few years away if we do everything right. If we test these questions appropriately with the newly available technologies.
Excellent, yeah. And the other thing that I noticed with these trials, in addition to all these different points that you brought up, was the fact that the first two trials, the Simplicity 1 and 2 trials, were done in European countries, as you mentioned, and these included primarily Caucasian race. About 95 to 97% enrollment was Caucasians, whereas in the United States, about 30% of patients belong to other races, primarily African Americans. And we have known for years now that hypertension, the pathophysiology, is different in African American race as compared to Caucasian race, and there's more water retention, sodium retention in African Americans, and perhaps maybe that may have also led to these sort of issues. I understand the Simplicity 3 paper that was published in the New England Journal of Medicine. When they did a subgroup analysis, the only thing that stood out was is racial difference, where the Caucasian race blood pressure reduction was significant. And perhaps that's also another point that we need to look at.
Yeah, I agree. I think it's an excellent point. I certainly, like any other factor we would look at, we're speculating. We don't know for sure. But there are biological reasons why a given therapy may be more or less effective in any subpopulation, and so I think there's a lot more we need to learn about that.
So it seems like you don't think renal denervation is dead now. We just need to find a better population and maybe procedural changes.
No, I think it's far from dead. I think we all got caught up in the enthusiasm of a potential new blockbuster therapy and perhaps got out a little bit too far along that pathway, if you will. And we need to go back and do a little bit more preclinical work and figure out the best ways to renally denervate. Not just the best technologies, but the best ways to apply those technologies. And then perhaps redesign trials with varied populations. And that could include anything from patients who are antihypertensive naive all the way out to resistant hypertension on multiple agents. There's a lot of dialogue about what the right design in that respect will look like. But perhaps tweak the endpoints so that we're looking at ambulatory blood pressure, perhaps looking farther out than 6 months, and so on. So we have a lot of work to do from the preclinical phase all the way through randomized clinical trials, perhaps with longer follow-up. So not dead, but delayed.
Delayed. Great, thank you. Thank you, Dr. Aronow, for all your knowledge.
My pleasure. Thanks for having me.